be Cora if you want to start, Julie.
Yeah, if I will, because it's 2 o'clock and we've got quite a big agenda. If you can start recording now, Sarah, that's absolutely fine. So welcome to the September meeting of the George Eliot Board. It's a meeting in public, not a public meeting. There will be opportunities at the end of our session for the public to actually ask questions. It's a very busy agenda this afternoon. We had our full boards meeting in August, which has meant that some of those reports have come into the September agenda. This morning we've had a workshop with a considerable discussion around the progress of the ICB. We had an opportunity to speak with Danielle Orme, and also around a really good discussion around discharge to assess and a business case coming to us next week. I don't want to stifle discussion this afternoon, but there are a number of reports. I think for the public's benefit, it's useful to know that many of the reports that are seen by board have already been scrutinised by its committees, particularly the annual reports this afternoon have been looked at by quality committee. And I would like authors and presenters to actually bear in mind that we have got a big agenda. So when presenting, can we just keep to the key points that need to be highlighted from your perspective? And just remember that scrutiny has happened. So with that, I will say, do feel free to contribute there. Don't feel constrained because we've got a tight agenda. So we're quorate. Any declarations of interest? I think, Anil, you might have one. Anil doesn't appear to be here. I think there was an amendment to Anil's. And from my own point of view, I've got one new declaration. I've recently established a company called Craftikin, which is a crafting company. It has no bearing on the NHS, and it doesn't affect my role at George Eliot either, but I will add it to my declarations of interest. The minutes of the public board meeting held on the 5th of July, are we happy that they are a true record of what was said? If there are no hands up, can I say thank you very much to Ness for producing these and agree them? We will note Anil's. He has, outside of the meeting, noted a change to his declarations. Action list and matters arising. On the action list, I think there are a number of complete, or there are dates in the future. Has anybody, just around those complete or dates in the future, has anybody got any comments around those or any clarity required? Natalie.
Yes, Julie, just on the action 221708, which was asked by Councillor Pagada back in February, I believe. Just to add to the note that I've already mentioned in there, now that Badgernet is being integrated, we are hoping that in the future we will be able to pull the demographic that the councillor asked for. But we do need some time for that to settle in. So I would suggest that I can review and come back to the board in approximately Q4 to be able to state whether we could provide that demographic.
Okay, can we communicate that? I'm not sure whether Councillor Caldecott's in the audience, but can we communicate that to him so he knows what's happening?
Yes.
Thanks very much. Robin?
Yeah, thanks, Julie. There is an action on there that's been carried forward for a couple of months around the update on the League of Friends cafe reopening. Yeah. And the latest date on that is the 3rd of October. So that's they're just finalising their training requirements and set up. So that's the date they're working to. So
that will be at the time of our next board, won't it?
Yes.
Round about the time of next board, so we can have some photographs too. Which is what we said. There are a number of actions on here that are associated with improvements in the performance report. I wonder if we could just put them together. They're coming, they're going to be action by the 4th of October, if we could pull them together, because they're just all over the place just at the moment. And Sarah, just any update on the new code of governance?
They've not yet been published, Julie.
Okay, thanks very much.
Thank you.
So if we're happy with the actions as they stand, if we can now move on to one of the actions was around a trust board briefing on workforce issues. We have got that briefing note in front of us produced by Gertie. I'm just going to move to, if that's okay with everybody, any questions or points of clarification that people may want from Gertie. No? Gertie, yourself.
It was just really to assure the board and members of the public that these matters are discussed through the Quality Assurance Committee and a number of other committees like the People Experience Transformation Board. So whilst they are being received here for clarity and transparency, they do come through the QAC as well.
Okay, and if people have got individual comments, they can of course come back to you separately if that's okay. Thanks very much for that then, Gertie. That discharges that action. And if we can then move on to, I think it's your report, Glenn.
Thank you, Chair. I'm just going to pull out a few highlights from the report this month. I start off by talking about the winter plan that was published on the 12th of August, which is, as I note in my report, it's the earliest I can remember. And after 39 years in the NHS, I can probably safely say it's the earliest ever then that we've had a winter plan. And I think that helps to signal the concern, the importance, the pressures that we're going to face over this winter. The plan sets out the introduction of a new assurance framework that integrated care systems will be required to complete, and I'm sure that will also involve assurances down to organisations like ours within integrated care systems who have a clear delivery role. The plan sets out the need to identify around 7,000 additional beds or bed equivalents, and bed equivalents are improvements in the pathway that reduce the need for beds, which are often the best solution actually, because just putting more beds in to hold patients in hospital when they could be elsewhere is not the best solution. So things like virtual wards and other pathway improvements are included within that. And it sets out a number of measures we'll be tracking over this winter, and the objectives, particularly around reducing the number of ambulance delays to ensure that they're freed up, to ensure that they're supporting more patients, and the challenges that are there for us around discharge. And this morning in workshop, we spent quite a bit of time looking at our discharge to assess arrangements locally and looking at how we can make improvements there. I think it's fair to say, though, with all of these things implemented, it will still not be enough for us to manage this winter. So we will be looking at some further measures. Nationally, there will be hopefully some further action on this as we approach the winter. I think some of the key messages for us will be about doing the things that we know work well. I also think we'll need to take a different approach to risk over this winter. When we went through the pandemic, we effectively discharged patients back home by balancing the risk of those patients being in a hospital compared to the risk of the front door and people not being admitted to hospital. And I think we need to look carefully at those risks again. By far the best thing to do is to not admit patients in the first place if they can be treated in other settings. And so for us, working particularly with our care homes, and there's been some great innovation around the use of technology to support care homes to manage patients without bringing them into hospital. We will need to get on a COVID incident footing over this winter. We hopefully won't be at a national level 4 incident, but I'm pretty sure that pressures will be such that we will need to make some rapid decisions and need to ensure that we make some choices around some of the priorities of activity. And we need to support our workforce. I really do hope that we are able to work to support our social care colleagues, particularly some of the pressures around domiciliary care. And that was apparent in this morning's discussion, the need to ensure that we have more workforce capacity in domiciliary care is a key one. So this will keep us very busy over the coming months, and I'm sure at each board meeting we'll be talking about the pressures and some of the resolutions that are coming forward. I'll then just talk briefly about one or two other things in the report. Firstly, the 3 boards meeting. As you said, Chair, we didn't meet in public last month because we did our first ever 3 boards meeting. In future, those meetings will take place quarterly. They will be in public in a Teams forum like this one, and they provide a great opportunity across the group for us to look at best practice and to identify our comparative performance and to share. And that's what we did in this first meeting, and it worked well. We can make some improvements to it. It identified, particularly when we looked at the financial productivity challenges, it identified the challenge of some of the business cases that were approved prior to COVID, not necessarily delivering for us yet for all sorts of understandable reasons, but particularly the cost of labour has gone up with some of our recruitment pressures, meaning that we're having to employ more agency staff. So the reducing temporary labour is going to be one of our key measures, not just for this year, but over the next 2 or 3 years, so that we can improve both the quality and reduce the cost of delivery. Great news to showcase the endoscopy academy, which has started, and our team's training others as an accredited training centre for JAG, which is great to see and a great accolade for the hospital. The community diagnostic centre opening, I talk here about the public opening and the increase in that capacity. Just prior to the public opening, we had a visit from the Secretary of State, and he was incredibly impressed and liked the model, actually, the model that we have cited, the community diagnostic hub on an acute site, but with protected capacity to ensure that we do our elective work. Great credit to Catherine and the team who pulled together the community diagnostic centre, and we obviously will be hoping that additional capital follows for the next phase of that, which will allow us to fulfil the full potential of that development. I then give credit to staff around their work around the Commonwealth Games, which affected the Midlands and was a great success. And then also Justine Whitmore, recognised for the work that she did on the vaccination programme, and a lovely photograph of her there receiving her award. And then the updates, I'll go quickly. So Directorate, some of the work on urgent and emergency care and radiology. We're doing well on diagnostic waiting times, so perhaps need to have a look at those, and when we look in the performance report later to make sure we're reflecting our true good performance. The use of the community diagnostic centre by GPs for X-rays is a great development. Being fully established with radiologists will be a great position to be in, which will be there soon. And our continuing really strong performance on urgent and emergency care. And then finally, the knowledge and skills, knowledge and library service, which is a joint service between George Eliot and South Warwickshire now, and has really strengthened that, not just from giving information to clinical staff, but also from a well-being perspective, and things like the book club that they've been running have really added to the culture and the well-being of staff. So that's all I said. That's all I wanted to go through. There's the list at the back of staff engagement visits with active, executive and non-executive presence in all of those. And I'm happy to take any questions.
Thanks very much, Glenn. A very big congratulations. Well done to Justine. Questions and comments, observations to Glenn? Glenn, it wouldn't be. Oh, there's one from Gertie.
It's not to Glenn as such, but obviously Justine has been a fantastic lead for us as the vaccination lead, doing antibodies and COVID vaccinations, and I just feel, I know she's with us today, so it's a real recognition of all of her hard work and the impact that's made, both in terms of keeping our staff and our community safe, because the hub is open to both staff and members of the public. And I'll take a quick moment just to remind people that we are gearing up for the flu and COVID vaccination boosters, and encourage both staff and members of the public to get themselves vaccinated as soon as possible. Thank you, Chair.
Thanks for acknowledging that, and really well done, and thank you, Justine. Big thank you from the board. Thank you very much. Sarah.
Yeah, just quickly to say as well about the knowledge and library services. Glenn, we looked at their report at the Quality Assurance Committee, and it was an excellent report, some really good achievements, and from things that may sound quite soft in a you know, when we're discussing some of our performance issues later, but things like the book clubs, but then to the other level of helping nurses and those doing master's degrees to understand and develop in their critical resource gathering and knowledge of how to write really good quality papers, which then goes on to have direct impact on patient care. So that was a really good thing to see.
Thanks very much, Sarah. I just got one question, Glenn, if that's okay. It was around winter pressures and the framework. There was, well, two questions really. In terms of those targets that are relevant to George Eliot, those areas, will they be included in the new integration report? Was my first question. And then other areas there are relating to ambulance services, and I wanted clarification about where ambulance services sit within the system in terms of ICB and ICP.
Okay, good question. So I think, yeah, we need to just double check, but yes, my understanding is the new board assurance report, which will go through to all three boards in the group, will have those measures on it. Of course, the ambulance delay is a measure of system pressure. It's not so much a measure of the ambulance service itself. Obviously, that sits with West Midlands Ambulance Service for us, although we do occasionally get East Midlands ambulances coming into our patch. And I think we will be looking more over the winter at a whole range of system level measures. And there's been some further discussion about that across the NHS over the last week. So we just need to make sure that our board is appraised on how all of those are going, and that will include a whole range of things, including the discharge issue that we discussed earlier, but also access to primary care. We play a really important role in making sure that those ambulance handovers are as short as possible, because it's all about flow, both within the hospital and outside the hospital in the wider system. So we need to keep tracking those. Generally, our performance is really good. I get an hourly report every single day on that, and always looking at the number of delays, the amount of hours that individual ambulances are delayed outside all hospitals in the Midlands. We feature very, very strongly on that, but we need to keep that performance up over what will be a difficult winter. Thanks
very much. Thanks, Glenn. Okay, thanks for that. We've received your report, as always, really helpful and well set out. Thank you. And we move on to estates. Robin and Kirsty. Handing to you, Robin, or to Kirsty?
And to Kirsty, thanks, Julie. She's the expert in the room.
Thank you. Good afternoon, everybody. I'm just going to take it that the paper's read. Glenn stole my thunder a little bit there. So I wanted to start off with the completion of phase 1 of the Community Diagnostic Centre, which we saw the first patient going through the door on the 15th of August, which was really good. We've now started in earnest on phase 2 and the enabling works in particular, with the Estates Department starting to relocate to the former boiler house next week. We've got an awful lot of stuff to move, so we're starting early. That'll enable us then to demolish the Tulliver ward, the EBME workshops and the estates offices, and the demolition notices are already posted, so you might see them as you walk around the site. In terms of maternity, we've paused the works to the main theatres while we look at theatre 2 in there, so we can see if there's a solution or a better solution than the one we have planned for the backup facilities while the works are being done. And we're just finishing a finalised design and getting costings for doing any works to room 2. And on a good note as well, the infrastructure works in the maternity building, particularly on the hot and cold water distribution system, are now finished. We're just at the point of whole system chlorinations and then a series of testing, so that's really good to get that one sorted out. The single rooms have been completed in A&E, so that now gives us 5 individual cubicles and hopefully will help us manage our COVID pressures through the winter. They've got negative pressure ventilation, so again, it's another plus point for us. The targeted investment funding that we had, we've now completed the works to install the 4th watcher in HSDU. And in terms of DPU, there's a proposal to undertake those works to install the ultra clean ventilation canopies in there in December and January during the quieter period. The Department of Health still haven't given us any feedback at all about our expression of interest for redeveloping the maternity building. So we still live in hope, but nothing forthcoming as yet. Space utilisation has been quite high on the agenda for us in estates as well. We installed some Occupy sensors into outpatients in December, and we've now got the data from that, and we're working with CSS to start look at where areas are underutilised and to maximise the use of that area. And we're also going to start looking at moving some people into Lewes House to free up admin accommodation in the main hospital that can be used for clinical work. And Coradio have now vacated the 4th floor, but the Trust has given them permission to still continue to provide a hospital service, and on the back of that they've just been granted their Ofcom licence. So that's good news for them, and we'll continue to support them to do that. And then as Robin mentioned earlier, I met with the League of Friends this morning, so the date of the 3rd of October is what we've got planned to open the cafe. We were there this morning and it was really good, the amount of people, visitors and staff that were coming round asking if they were open and couldn't wait to see them back. So it's really good feedback. So that's the report for the estates Q2, and if anybody's got any questions.
Thanks very much, Kirsty. That was well articulated, run through the report. Glenn.
I think you have to be praised for having probably the biggest sign ever in the community diagnostics centre produced across the NHS, which the Secretary of State really loves standing in front of and being photographed. So well done for that.
It looks fab at night when it's all lit up.
I just couldn't see that. I've not seen that, Kirsty.
I'll send you a photo, Julie.
Okay. Thanks very much. Any other questions of Kirsty? Robin.
Not so much a question, just to add to Kirsty's narrative on maternity theatres. So the work that's been done there, there was the initial work was around the change in the ventilation system because it was old and potential for failure. So that was the initial reason, but also what we did was pick up on a long-standing risk that's been in the organisation for a number of years, which is around our capability of having a second maternity theatre of equal size and proportion to the first, that is suitable as a direct replacement as part of business continuity planning. So we're using that opportunity in order the plans that Kirsty has discussed already builds that in, so it resolves a long-standing risk for the organisation as well. Thanks
very much for that update and clarity. I've just got one question about post-implementation reviews of all of these. Had the process for that? Kirsty, I think you nodded then.
Yeah, and the sort of with every business case, there's a benefits realisation section that's always done. So it's revisiting them. Usually let them run for a couple of months when they're open. I think the proof with the single rooms in A&E obviously will be winter. The community diagnostic hub, I'm sure Catherine and Jenny's team will help us with the benefits realisation for that. But it is a really important thing that to do, and sometimes it does get left behind a little bit. But I think with these, we need to really pick them up and you know, prove that they're doing what they say they do.
Yes, significant.
Which I'm sure they do.
Yeah, thank you. Thanks very much for that. With no other questions, thanks, Kirsty. I think you're staying for a later item as well.
I'm going to dip out and then come back if that's okay.
We'll see you later.
All right, thank you.
Thanks. And then we're moving on to Warwickshire North Place Delivery Group progress report. Again, assume the report's read. Is this you, Jenny, with Salma?
Yes, it's me, I think, today. So just assume that the paper's read, but I am just going to just pull out a few highlights if you would, but I will be brief. The couple of highlights that I wanted to note was in terms of our reporting, there were two programme areas that we'd identified as requiring some additional assurance, and we progressed with some conversations with colleagues to move that forward, and I'm pleased to say that we have had positive meetings for both the long-term conditions and for the mental health area, so we can take some assurance on that. I just wanted to note that we know that we need to review and refresh the risk register, so whilst that is undergoing a refresh, that is, we still do have a number of red risks, but we are going through a refresh with all the SROs, so we hope to be able to update on that position. And then just from a delivery point of view, I just wanted to highlight some specific sort of areas of success, which I think it's really important to just raise really. Under the long-term conditions programme of work and wider determinants of health, we're pleased that we've been able to take forward the development of remote monitoring in relation to end of life with our Marianne Evans Hospice colleagues. Under our integrated community and rapid response, we wanted to just indicate to the board that we were successful in partnership with South Warwickshire Foundation Trust on the discharge task force, a bid opportunity, and I think that connects in with the discussions that we're having this morning around supporting that area of focus, particularly moving into the winter. So I think that's important to just raise. There are a number of other things that I could pull out, but I know that we are short of time. But did also want to just raise the fact that the cancer pathway work, we were reporting in a previous report that the referrals weren't on target, and we did some investigations to understand why that was, because we felt the need was there, and we are pleased to report that the referrals are now in line with the trajectory we had expected, and we are seeing that move forward. So that's a really positive thing, and it was really about communications, etc. Finally, I'd just like to say, in the context of our developing readiness at place, we are actively undertaking some workshops with our place colleagues to develop our approach to pathfinding in terms of how we respond to the opportunities under the new arrangements under the Health and Social Care Act, in terms of how we as a place can respond and work within the ICB and with the care collaboratives at place, and really cement our opportunity to support place delivery within Warwickshire North, building on the work that we've been doing over the period of time. I will happily take any further questions or comments. There's a lot I could have picked out of the report, and it's a shame that obviously time pressing to just pick out a few highlights, but I hope people have enjoyed the report and the progress that we're making.
Yeah, very much so, Jenny. Thank you very much. Questions, comments, observations to Jenny? I think for me, Jenny, there was very much this work was acknowledged in our discussions with Danielle Orme this morning, and that opportunity to really bring this to life in the context of the system is really important. I've just got one question, which was around in the report, we very clearly talk out the measures for improvement. There aren't dates for everything, but I just wondered what was the proposal about interim reporting on, because there are realisation dates, but I wonder if there was any proposal for interim reporting.
Yes, thank you. As you see, we've got profiles for each of the programme areas, which is obviously a development from where we were originally, where we didn't sort of have those sort of profiles, and each of the projects and programmes are slightly different because of the nature of the projects and programmes that are within those. But there's two things that are happening. One is around, as you say, those sort of outturn dates, I guess, in terms of which are the longer term dates that we're working to, but also then thinking about interim measures and process measures where we can kind of check that we are on progress. So we are working with the teams across the projects and programmes to further enhance that. You'll see there are still some gaps in those profiles, but I think we've made progress. And so the point that you're making in terms of those interim milestone deliverables is where we're going to focus. I think sometimes project teams are don't always we have to encourage them to almost like identify the stepping stone deliverables that they achieve, and often they hide their lights under bushels, and that's why the improvement stories that go through the improvement board are also really important, because we also look at interim progress deliverables as well. But that is something we will pick up and strengthen as we go forward, and we can reflect that in further reporting, and I think it's a point to encourage people to do. So thank you for that observation.
Thank you. Thanks, Jenny. Glenn?
some really good work in here, some of which is obviously quite mission critical for the winter, as discussed earlier, particularly Robin's unscheduled care work stream. One of the things that refers to in there is the work with West Midlands Ambulance Service around avoiding conveyance to hospital. I'm really keen for us to make sure that we have that in place as quickly as possible, particularly with the clinicians being able to give advice to the crews, but also the frailty model that we've been looking at of pulling patients out of the ambulance queue and sending a specialist frailty response. So it's just one for Robin, really, and I know you know this is important, Robin. Just whatever we can do to help you to expedite that piece of work would be great.
Thanks very much, Robin.
Yeah, thanks, Glenn, for that. I think obviously, you know, it's at the forefront of our mind, both in the winter planning and also just moving forward in general in terms of urgent care and the capacity and flow issues as we go forward. I think there's some really good work that's happened across the place system. We heard a really good presentation at Place Executive last week, where there's been a number of schemes developed in the community, and also linking back then to a single point of access type arrangement that would then make it the ease of accessibility. And one of the part of that conversation there was directly linking to this: how do the ambulance service and paramedics access those services, and how do they get consistency in response, more importantly, because we know their time is limited with individuals in their own home, and they need that wraparound assurance that they've got a positive response at the end of the phone. So that there's a lot of work going on at place level on that.
Okay, I'm just very conscious of time. Are the hands up in response to the point, or could they be raised in the comments column for now, if that's okay? I'm just conscious that we've got a lot to get through. I don't want to, but we'll make sure that those are picked up. Thanks very much. Because I have allowed us to overrun very slightly into that section, but I think it shows the importance of the place work. We're moving into our quality section, and just to remind members of the public that these reports are scrutinised in some detail by our quality committee. If the presenters of the next reports can remember that, but actually to highlight the key things so that we can allow some discussion and some questions in the time that we've got allotted for this particular section. Natalie, welcome, and it's over to you. You've got the floor for quite a lot of the time.
Thank you. So I'll start with the regular nursing and midwifery safe staffing paper, and I will take it as read, as we have suggested, and just highlight a few sections for the board's attention. I think it's to note that July was particularly a difficult month for staffing due to the virulent Omicron variant 4.5, which affected our patients and our staffing levels. And this was borne out in the number of shifts requested through NHSP and the lower fill rate at 78%. We undertook a lot of internal mitigation and moves of our own staff, which meant that we did not need to go off framework. Our focus remains on recruitment and retention, and we're working at system level with Swift and UHCW on the Project 1000 ambition. And Jeanette Holberg is leading that from a GHE's perspective. With the recent recruits that are in position and with ones we're awaiting to onboard, we will be an RM vacancy of 15.3% and a healthcare support worker at 14.3%. I think it's to note that maternity and our AHP position are currently looking and are really reasonable from a national perspective, but we will obviously pay close attention to that and not take our eye off the ball if those numbers move at all. The report highlights the quality and safety aspect that goes in correlation with safer staffing, and we monitor any red flag incidents in relation to those, submitting against the national definitions and noting if any harms occur. You'll see in the report it pulls out how many day ticks have been reported, how many were mitigated, but I am glad to say that there were no actual patient harms that came about due to lower staffing levels. And finally, to mention our focus on international recruitment. We're looking forward to welcoming these new recruits into the George Eliot family and building on our previous successes of that recruitment, but also of retaining those nurses and ensuring that their onboarding process, their pastoral care is of utmost importance to us. Happy to take any questions about the paper.
Thanks very much, Natalie. Questions? Comments? Thanks very much, Natalie. I know that the report's considered in some detail. I just, well, shall we move on to Ockenden in the absence of any more detailed questions from the board?
Thank you, and I'd like to welcome Claire to the board to be able to go through maternity Ockenden paper.
Hi, Claire.
Hi, Julie. Thanks, Natalie. Okay, I'll take the report as read, and this is a very brief update on the progress of work on the findings of Ockenden Part 1 and 2. Our current compliance against the Ockenden immediately essential actions have been reviewed through our trust governance processes, through the local maternity and neonatal system, and also through a recent submission to NHS England earlier on in August. Since writing this report, George Eliot has actually had its NHSE Ockenden Insights visit, which took place last week. We had to submit a large volume of information, as did other organisations, and that was shared with the NHS England team. And during their visit, they met with staff, the executive team, the directorate leadership team, and service users also. Initial feedback was very good. We are waiting for our formal feedback, which we are expecting by the end of this week. But the visit was felt to go very well by the regional team. One of our areas of challenge continues to be around the full compliance in relation to Saving Babies' Lives Care Bundle version 2, and this mainly relates to the areas of additional skills in sonography. We are accessing specialist training for that to try to ensure that we are compliant with that in line with the national guidance. I think it's really important to acknowledge that as part of the national programme of work as well, that George Eliot has already had one deep dive into its Saving Babies' Lives compliance, which is relevant to Ockenden. And we do have the second part of that work with NHS England this Friday. So we'll be able to provide a much more detailed update in relation to that in board in a couple of months' time. I'm happy to take any questions.
Thanks very much, Claire. Questions of Claire? Sarah?
It's really a comment, and because we're in a public forum and as a board, aware that many of the board will be aware, and Claire can pick up and correct me if I'm wrong, but you might read in the Ockenden that lots of things are immediate actions, and that could then raise concern about why we haven't fully completed all the immediate actions. And it's important to know that at the Quality Assurance Committee, we have gone through those as the team have themselves in detail, and all the actions have been started. Most, we believe, are completed, but until we can evidence completion and benefit, then we are not saying that we are fully compliant. And I just think that it's drawn out in the paper, but I think it's just important to be explicit on that we're not doing immediate actions. You and the team are really actively pursuing those, and whilst equally important to say we've still some distance to travel, I wouldn't want it to be felt that as a Quality Assurance Committee we're not scrutinising what you are doing, and we are assured that things are moving in a positive direction.
And I think it's important to acknowledge as well that the IEAs are made up of huge amounts of individual elements as well. And some of the things that we are currently not compliant with, many of those are out of our control at George Eliot. So they're regional and national steers on things. So they're elements that other organisations will be struggling with as well.
Absolutely. So we're not making excuses, but
No.
I think it was just important to articulate that. Thanks.
Thanks very much for that assurance and for that clarity of the scrutiny that happens at Quality Committee. Rosie.
Hello. Thanks for the report. I actually put my question in the chat and it was more of a subjective question. Obviously, Ockenden activity is really important as a way of making care the safest it can be. But my question is about how midwives are feeling about the additional activity and the scrutiny. Do you think midwives feel supported and safe in this activity themselves, or do you think it's creating additional stress and anxiety that might actually affect care?
I think, Rosie, that at George Eliot, I think we've been very open and transparent with the staff. So I've done engagement events with the staff. 2 of those have happened in the last 3 months, where we're updating the staff where we are with our current position with Ockenden. And I think it's fair to say that, you know, as a midwife, and when your profession is very much under the spotlight, we are providing additional pastoral support to staff as well, because, you know, Ockenden is on the news, isn't it? And we're seeing other organisations having reviews as well. So we're doing a lot of work with our staff and with our students to make sure that they feel supported in the workplace. And I think there was a discussion about staffing with Natalie in a previous paper. We are very fortunate to have very good retention rates at George Eliot and very, very low vacancy rates within the midwifery profession. So I feel that we're doing well at George Eliot with that.
Thanks very much for that, Claire. And just moving on, is it yourself that's going to present the CNST report, Clinical Negligence Scheme?
Yes. Okay. Again, a very brief summary, as a more detailed report will come, I think, in November to Trust Board. Just to acknowledge that nationally, obviously, we were notified earlier this year that the new submission date for the maternity incentive scheme is now January 23. There has been additions to the requirements, which has affected compliance for George Eliot. Currently, we still have 4 standards that are unchanged and remain fully compliant, and work is continuing to address changes within those national requirements. As I discussed earlier with relation to Ockenden in regards to saving babies' lives, we are having our deep dive review this week, where an external review will happen from NHS England around our current compliance, and then there'll be offers of support for trusts that need additional support for compliance. However, it is looking very likely that we will not be fully compliant with that by the time January 2023 comes, and that is the picture elsewhere as well. The remaining 5 that are currently amber at this reporting time, they are likely to be met by January next year, and there's additional work that's happening within the directorate and within the trust to be compliant with those, but we're confident in the remaining 5 ambers as well.
Thanks very much, Claire. Thanks for your honesty and clarity around that. I've just got one comment, really, is there's a plethora of reporting requirements associated with CNST and Ockenden, and they're all aimed at ensuring safety and improving quality. And I just wondered if there was any thought of how these can be combined in terms of reporting, or is it that they have to be separately reported?
I think there's been a lot of work done on the reporting for George Eliot, but I think there is also a national suggestion that there will be one piece of evidence that will be required for all of these elements for maternity. So we know that's coming. But I see Natalie's got her hand up. Natalie and I are discussing reporting and how we do that. So I'll let Natalie answer the question.
Okay, thanks. Natalie.
I think you just did, Claire, really, that with myself coming new into position, with Lorraine joining us just this week, and with Claire, it's the ideal opportunity to review all of the reports, Julie, and to be able, for the maternity team particularly, be able to condense them down hopefully into one report and decide on the frequency of when they come to both quality assurance and the trust board, making sure that we do meet the national guidance, of course.
Okay, thank you very much. Glenn.
Yeah, I think that's really important, because there are going to be further national reports on maternity services with no doubt further recommendations. So I think streamlining that into one process. I think we've talked before about trying to do that across the group as well, so that we can share a bit of the burden of that piece of work. But I think with all of this, it's great to have so many recommendations for improvement. We've also got to be able to stand back and just be assured that we've got safe, effective services, because just ticking boxes of implementing things doesn't necessarily do all of that. So I think there's and that's why I think things like visiting and talking to staff is an important part of that assurance also.
Thanks very much, Glenn. Thank you, Claire, for joining us today and for the work of the team. And I know there's a lot of reporting here, so thanks very much.
Thank you.
And we're going to move on now to mortality and learning from deaths with you, Catherine.
Thanks, Julie. Well, hopefully the paper's self-explanatory. You can see that in our mortality indicators, both SHIMI and HSMR have increased. SHIMI is 111, which is within the expected range, but if it continues to rise, it will become outside of the expected range. And HSMR is 122, which is outside the expected range. We've seen quite a rapid deterioration over the past few months, and we've done some deep dives into why that might be. And the main things that are coming out of that are around our coding of palliative care, where there has been a change since December in terms of the way that the coders have coded palliative care, and that has a direct effect on HSMR, which you can see is disproportionately affected compared to SHIMI. And the other thing is we've got a higher percentage of frail older patients compared to our peers, but a lower number of comorbidities recorded in those. In terms of, the first question one has to ask oneself is what is going on from a clinical perspective in terms of whether there's any concerns around the quality of care that we are providing patients. And I think we should be reassured that you'll see from this report the number of cases that are reviewed by the medical examiner, the number of structured judgment reviews that we've done. And when there is one case in this quarter with very poor care, which has been subject to a tabletop review, and I think in that case, actually, it wasn't felt to be very poor care in the end, but we're not seeing a rise in complaints or concerns from bereaved families. So, and the other piece of work I just want to draw to everybody's attention is that we are focusing on Sepsis September this month. So a lot of work going on with our trust about the recognition of the deteriorating patient. And we will be welcoming Melissa Mead, who lost her son William to sepsis, on National World Sepsis Day. I think it is on the 13th of September, to come and talk to us. So this report talks about the numbers and some of the coding issues that affect that, but I also want the board to be aware of the work that we are doing from a clinical perspective to make sure that our staff are focusing on the deteriorating patient treatment escalation plans at all times.
Thanks very much, Catherine. I think that point about it doesn't correlate to the standard of care is really important. Questions of Catherine? Any points of clarity or observations? No, thanks very much, Catherine. I think we're now moving to Natalie, Natalie Green, for Patient Experience Report.
Thank you, Chair. So this is one of the first of the annual reports, and in the interest of time, I will be extremely quick. This has been discussed at detail at the Quality Assurance Committee. What we tried to do within the annual report is actually answer the questions on what we're doing for the improvement. We've pulled out the themes of what our patients, families and carers are telling us from all angles of, whether be that the patient surveys, be that from the friends and family tests, be that from complaints or the comments that they leave. The themes that we're picking up mainly are to do with communication and some of the inconsistencies that communication is having for our families and our patients, coupled with delays. And also highlighted in the last year has been an element of lost property. Within the report, as I've detailed, we have put together what improvement plans the directorates are undertaking in light of those themes, but any other of the themes that are coming through and feedback that's coming through to them. We are moving forward with our listening and learning together framework, which should be coming into its fruition from October of this year, creating new infographics to be able to really demonstrate the great work that is going on, but also the improvement side. And the report provides details of how the organisation and individual areas are supporting, with the help of the patient experience team, driving forward that improvement, but especially listening to what we're being told and how we react to that and change for the better for the patients and the community that we serve. Happy to take any questions.
Thanks very much, Natalie. Questions for Natalie? Rosie.
Just a quick one. I might be behind the times, but have visiting restrictions now been removed?
They have, Rosie. We have, and we've updated all of our public facing sites, but also our internal mechanisms to be able to do that. We have put those timings predominantly to the afternoons. However, we do have an open policy if there is a compassionate need. We're open for carers at any stage and any families that are unfortunately visiting their loved ones because of end of life issues.
Thank you.
Thanks very much. Anil.
Yeah, very good question, really. Will that be with Civility Saves Lives training?
I'm sorry, Anna, I didn't quite get that. Oh, Gertie's got a hand up.
I'll
Okay,
pick that one up, Anil, because Sue will pick it up in the Speak Up report as well later. We have trained over 1,000 members of staff now across George Eliot and Swift, and we've seen a significant improvement in the numbers trained with the addition of Deepa Mansey's post, which was, as you know, originally funded by the charity, but has now moved to a substantive trust-funded role. Sue and Deepa are working on developing a sort of second responder training, as well as the basic level Civility Saves Lives. So it is progressing really well and is becoming really well embedded across both organisations.
Thanks, Gertie.
Thanks very much, Gertie. Thanks, Anil. I thought Umar had got a question, but
I did, yes. Sorry, it's thanks for that, Natalie. I just wanted to ask in terms of the correlation in patient experience and the link between the more vulnerable communities and them being able to gain access to the complaints process, but also being able to kind of feedback, and whether there's any correlations where, you know, people from Black and ethnic minority communities, for example, maybe, you know, potentially getting a better or worse service, whatever that might be. Have we got ways of analysing that data, and do we capture all of that?
We capture by ethnicity, yes, definitely, particularly through the majority of our feedback, inpatient surveys and our complaints and FFT. To be able to do that analysis on if there are variation either way for a better service or a poorer service, that would be something that we would have to particularly maybe undertake a bit of a more detailed analysis on, but nothing has strikingly come from that at all. And we work very closely with Healthwatch and our external teams and patient experience, patient forums, to be able to have that intelligence if there are any problems that are being raised within the community.
Okay, that's great. Thank you. That's really helpful. Thank you.
Thank you. Thanks very much. Thanks for that report. We'll move now to Catherine and trust-wide incidents.
Thanks, Julie. There's 3 things I'd like to pull out of this report, if I can. The first is to draw your attention to the graphs at the back of the paper in Appendix 1 and Appendix 2. We've gone back in this report over a sort of 5-year period to look at the trend around incident reporting, because one of the things in our patient safety strategy is that our ambition should be that we see a high amount of reporting and a lower number of harms. And I think you can see over time, obviously COVID has affected that there has been a general trend upwards in terms of incident reporting without a corresponding raise in the harms that we're seeing. The second thing I want to pick up on that is around the COVID reporting, which rather skews everything. The reason being is that by the advice and guidance that was published in October 2020 was that anybody who acquired hospital, probably or definitely in hospital, should be reported as a moderate harm. The definition of a moderate harm is an unexpected or unintended incident that resulted in moderate increase in treatment, possibly surgical intervention, cancelling treatment, transferred to another area, which caused significant but not permanent harm. Most of the cases that we're reporting at the moment are people picking up COVID incidentally, which is becoming harder because there's no restrictions in the public, no mask wearing, no social distancing. And then again, we've relaxed our rules around visiting and all the rest of it, which is absolutely what we should do. But we now have this disparity where we're reporting quite high numbers of moderate harm related to things that are not actually quite meeting that definition. So I hope that in time, our regulators or the NHSI will change their guidance on that, because that is, I think, not helping us to be able to see things clearly. And then the final thing that I want to pull out of this is about the introduction of PSIRF, which is the Patient Safety Incident Response Framework. The guidance for this was published in late August, and we have 12 months in order to implement this as an organisation. It's a whole-scale change in how we manage incidents, moving away from the current process of doing root cause analysis investigations where there is moderate harm, right through to thinking about using different techniques to get the learning in order to reduce harm in the future, no matter what the level of harm is. And there's a lot about how we support our staff. There's pages and pages of reading with this. So Natalie and I are working hard on our homework, but I think in time we will need to come back to the board with what we are intending to change in the incident process. And hopefully I can update you through these quarterly papers. You're on mute, Julie.
Gosh, gone all day without doing that. Thanks very much, Catherine. Any questions of Catherine? Points of clarification? No, I think it's still with you, Catherine. We're moving into the integrated performance part of our agenda with the integrated performance report.
Okay, right. Well, I'm just going to try something different this time, if I've still got it on my phone. Yes, so I want to focus on some of the things where we are, where we can see we're not on track with a number of areas, but try and link this back to national performance, because we've now got a tool that helps me to do that in real time through the Daily Telegraph tracker, which tells us where we are performing compared to national performance. But then I want to talk about what we're doing about this as an organisation and how we're going to improve, because in almost all areas we're not meeting the target, the standard that was set, and therefore we are not complacent at George Eliot, and we will try and continue to improve because that's what's needed for our population. So I think if we start, we've discussed the mortality, so I won't revisit that. In terms of the emergency department performance, we saw 78% of patients treated within 4 hours in our area, compared to the national performance of 71%. We're in the top 25% of trusts in terms of ambulance performance, but I think the thing to draw to the board's attention, Glenn's touched on it already, is we saw a higher number of ambulance delays over an hour in this month. The culture in our emergency department is very much that is our problem, not the ambulance service problem, and we will work very hard in order to tackle that. But that's one area where we've still got a bit of work, I think, to do, which links to bed occupancy that we'll come to in a moment. The other area I think I want to just draw your attention to is in our cancer performance. In terms of some of these metrics, we're actually doing quite well. So if you look at the 14-day referral to being seen, we're doing well on that. The 31-day treatment, we're doing well on that. The area we're having a bit of difficulty with is on the 62-day target, and only 50% of our patients met this. To put in context some of the challenges that we're trying to deal with as an organisation, we have seen a high number of referrals in a number of specialties, and actually to deliver the 14-day target has been a huge achievement for these different services. But in terms of bowel cancer, after the death of Deborah James, we've seen going from about 100 referrals for suspected bowel cancer a month to 300 referrals for suspected bowel cancer. So that's quite a huge thing for colleagues to deal with. But what I've agreed with Robin is that we'll bring back a CAS card on the factors that are affecting particularly the 62-day performance. Some of these are outside of our control because we're reliant on other partners to help with treatment. So it'd be good, I think, to get a really clear picture of that for the board. There's some areas for celebration. So we managed to maintain things like our statutory and mandatory training rates despite all of this. But we've still got some work to do on appraisal rates, which has improved a little bit this month, but still not where we need it to be in terms of the organisation. And Glenn touched on diagnostics and wanted to focus on this. I've written down, but we were at 97% of patients needing a diagnostic test, getting their diagnostic test within 6 weeks of referral. And that compares to England's average of 73%. So it's an area where we do very well in. At the moment, we've got some challenges around echo and with cystoscopy, and those have been really difficult for us to do. But on our radiological testing, things like CT, MRI, doing very well there. What's the cause of the underlying problem? So Anna would mention ERF, because we're not delivering 104% of our elective activity for that we did in 2019-20. And I think as an executive team, we have focused on 3 areas that we're doing a lot of work on at the moment, all of which relate to this. So that's about reducing bed occupancy so that we can get patients into hospital who need to be in hospital, offload the ambulance, improve our emergency performance there. Reduce the waiting times for treatment. So we did a bit of focus work yesterday. We've got some more focus work with the surgical teams tomorrow about the things that we need to address in order to really change gear in that. And the third thing, which Gertie's talked about in her action that we started off the meeting with, is about increasing staff availability. And as you can see from what Gertie submitted earlier, there's a lot of work going on about how we make sure that our recruitment processes are as effective as they can be in a challenging workforce market. So I guess that's where I'll leave it for now, Julie, but happy to take any questions or direct them to my colleagues if they're particularly detailed.
That's really great, Catherine, to actually for the public's information, there's a very robust performance management framework in place, which non-executives do observe. But what, Catherine, you've managed to do there is just to bring out the most important areas and the 3 areas that would make the biggest difference. And I think that's really important and really good to do that. Can I just ask if people have other questions? I just have one myself. I don't think so. I think you wowed people there, Catherine, in terms of the way in which you presented that. I've just got around the 62-day, is any concern that might be felt? And I think we've said this before, in terms of people, that 62-day target is around diagnosis to treatment, isn't it? And is what happens about harm during that period?
I'm going to defer you to Robin, who could more accurately answer that.
Yeah, thanks, Catherine. I think, Julie, we've got the cancer services teams, the pathway trackers, who monitor the patients on each of those pathways. And obviously, any patients that then have extended waiting times are reviewed, and a harm review is taking place on those patients. It was discussed at one of our quality assurance meetings earlier this month, and we'll continue to monitor that to ensure that we've got that relevant assurance.
Okay, thank you very much. Thanks for that assurance.
And just to say, Julie, we did take a paper through the through to QAC, looking at the cancer and RTT issues. Not related to that, you can see in the incident report there are some themes around some incidents, but they don't relate to the cancer delays that I'm aware of or that are coming out through our incident process.
Thanks for that. Thank you. Glenn.
Just a minor correction there. The 62-day standard is from referral to treatment rather than diagnosis to treatment.
Okay, and because I was linking it to, because our diagnostic figure being so good as well, it has an impact in that respect. But thank you for clarifying that it's referral to treatment. Thank you. Thanks very much. If we can now move on to Capital Q1 report, and Michael, assume the paper read. Anything that you want to draw out for us?
Thanks, Julie. Yeah, at the moment we're showing we're slightly off track of our plan. We're about 400,000 behind year to date, and that's because we had to tender our wellbeing hub. That's now been done. I'm expecting that to work to get underway quite quickly. Therefore, we're forecasting that we'll hit the year-end plan. Got a slight overcommitment at the moment, but we'll manage that through slippage. Capital envelope agreed with the system was 10.1 million, which included the 5.5 million for hopefully the phase 2 of the CDC, assuming it goes ahead, which Kirsty also talked about earlier. We have got the enabling works in place, so we're hoping to start that build in November. We're still waiting for feedback on the case, and we believe there might be some strings attached to money. At the moment, there is potential risk to the system capital of somewhere in the region of 7.4 million. So there is potential that we could see some reduction in our capital programme later on in the year. Happy to take any questions.
Thanks very much. Michael, any questions of Michael? Thank you for that report, noted by the board. Thank you. We're now moving into governance area of the agenda. First one is around annual review of standing orders and financial instructions, which I can say has been through audit committee. Anything that you want to say in introducing this report, Sarah, Michael?
I think.
Sorry, go on, Sarah.
Michael, I was just going to say the covering sheet outlines what the main areas of change are. The standing orders, they're quite straightforward amendments, and I know there's been some group work on the SFIs and scheme of delegation. Michael, I don't know if you wanted to highlight anything of that or just take it as read and propose the amendments for approval.
No, I was just going to say what you said, Sarah, that it's obviously it's took longer than usual because we've obviously done this across the group with Swift and Wye Valley. Obviously, this is to try and assist with smoother workflow through shared services. I can say it's Swift, I believe, have already approved the changes.
Yeah, I think this is what audit committee heard as well, that it brings us all in line as a group. So are we happy to approve this review of standing orders, financial instructions? I think that's a yes, approved.
Thank you.
Thanks very much, both. Sue, over to you in terms of freedom to speak up. I think you possibly heard that we are struggling with the agenda here, so please assume that the report has been read. Anything that you want to bring to our attention?
Absolutely. So I think the key highlights for me are that there's been a lot of new guidance come out from the NGO and NHS England. You'll be familiar that a couple of years ago we had to do our board self-assessment. That's due for renewal again under new guidance. So there's a review tool, there's a gap analysis tool based on casework that the NGO have done around different trusts and organisations, and there's also new guidance from NHS EI. So just sifting through all of that information ahead of our board workshop, which is due to take place in December. So in October, during Speak Up Month, I'll be sending out some questionnaires on MS Teams for you guys as board members to interact with that information, hopefully making that a bit more interactive than us just saying, we've done this, what do you think? So that's our plan. And then the other thing to highlight is all of the work going on for Speak Up Month. So thank goodness to having Deepa in the team now, as well as our wellbeing advisors, because we've been able to put on an even bigger programme than normal. And thanks to Gertie for supporting that as well. Culmination of events is the 11th of October on our conference day, and we've got lots of other activities, and all of the theming is based around wellbeing. but also based on the NGO's theme of freedom to speak up for everybody. So we're doing speak up for civility, speak up for safety, and speak up for inclusion. So those are our sort of topic areas. And I can see, Umar, you've got your hand up. So
I have. It's lovely to put a face to the email. So lovely to virtually meet you. Obviously, for those of you who don't know, I'm been allocated the responsibility of board sponsor of Freedom to Speak Up, which I'm with yourself, Sue, at some point, and Gertie, for us to think about ways that, from a board perspective, we can really raise this profile of a critical area of work. And with my other hat on, I sit on the National Board of Health Watch England, which has Sir Robert Francis, who actually came up with the concept. So for me, anything I can do to promote and make sure that we get as many people supporting it is absolutely going to be a pleasure. So just thought I'd just add that in, Chair.
Thanks very much, Umar. It's good to get your support. Is there anything else that people would like to ask of Sue? I'm sorry that we're pushed for time this afternoon, Sue. No, thank you very much. I think we're receiving that report and noting it as our biannual report. Thank you, and thanks for all the work that you do. And we're on to ratified policies. Catherine?
One policy was ratified.
Yeah, fine. Happy with that? Fine, absolutely right. So I'm just very conscious we're into the section on annual reports. I do want to be able to leave a little bit of time at the end of the agenda for questions. So I'm seeking a bit of support from my colleagues. I'm just going to ask Sarah, first of all, just to give some assurance around the fact that these reports have been well scrutinised at Quality Committee, and then I'm going to ask each person if you could just go through very quickly, but please, if you have got a question, then please don't let my haste to get through the agenda mean that you don't actually ask that question or seek clarification. So Sarah.
Yeah, so we had an equally full agenda at the Quality Committee with many of these annual reports. As you'll see from reading them, lots of very good work. There were elements of questioning and of clarity. I think some comments, a few minor alterations have been made to the report following the Quality Committee, and the committee did have a discussion actually and felt that of those that had been to the Quality Assurance Committee, we felt that we could, with confidence, recommend them to the board for board approval. So that was the position after our meeting.
Thanks very much for that, Sarah. So with that introduction, first of all, Adult and Children's Annual Safeguarding Report. Anything that you'd like to say, Natalie?
Leading on from what Sarah has just said, I think it would only be right for me to say to the board that the areas where we recognise we're non-compliant, so level 3 training, we have a trajectory and plan in place which is being met, and we should be fully compliant across all of our staff groups for level 3 safeguarding training by October. The IDFA that was referred to as being a service that was extremely valuable, but the money for that service had come to an end. I can happily say that this has been reviewed with the commissioning, etc., and it is back in place. So I think that is something to be highlighted and to be celebrated, that it's there for our staff and for anybody that needs to access. To state that we have met all our statutory duties, but also to highlight, as it does in the report, that all of our referrals, be they adult, maternity or children's, did actually increase in the year that the report is pertaining to, and we are monitoring that. But successfully, we have recruited into the investment that the trust put into safeguarding, with the increase in numbers across the whole of the team.
Thanks very much, Natalie. That's in response as well to obviously the work at QAC. Very big thank you to everybody that is involved, and it's everybody's business, but those that are involved in safeguarding throughout the trust. Samara. Hi there.
Sorry, I'm going to try to keep it brief. This is an annual report for controlled drug governance really for the trust. And it's an annual report that I do as a controlled drug accountable officer for the trust. Overall, I think over the last year, the key focus areas for us have been that we have overhauled all of our governance around controlled drug management in the trust in terms of the policies and procedures. They've all been reviewed and updated, and we have new policies in place. We have continued to meet all our statutory requirements as a trust in terms of reporting and shared learning with NHS England as well. We have really focused last year around benchmarking ourselves in terms of governance to say where are we bid against the standard proceeding management nationally, CQC expectations, etc., and addressing the gaps through those as well. So that's in the reports as well. The focus next year now is building on the work that the foundations we've laid this year and building through those. And really, as I think Catherine picked up before as well, is that the key area of focus from my perspective as a controlled drug accountable officer, because what assurance I can give you is really as good as the assurances of the reporting I get from around the trust. So I'm really focused on getting our reporting improved, our DATAX reporting improved, and making sure that our incidents of DATAX reporting are of our no harm and reducing even our low harm incidents, but improving our reporting. There has been some improvement in our reporting and through DATAX, but there's further work to be done. So we are planning to support that through the September Medication Safety Month as a campaign, looking at different areas of medicine safety that we want to be sharing with our individuals around the organisation, and CD management would be part of those moving forward as well. So I'll just take any questions.
Thanks very much, Samara. Questions of Samara? I'd like to acknowledge the hard work that's been going on, and certainly in the audit committee we've met with you throughout the year, and that the work that you've done around drug wastage as well, and the concentration of effort there has been great. So thank you very much for that, and I can give assurance around that to the board. So thank you.
Thank you.
Okay, we can now go back to you, Natalie. Infection prevention. Control.
Thank you. The year was another one that was predominantly focused on the COVID-19 pandemic, particularly during December and March with the Omicron variant that came into place that I think everybody is well cited on. So throughout the report, we have also focused on our other hospital-acquired infections, as we should do. And I am very pleased to report, apart from one MRSA bacteremia, which was the first in 5 years and was a very unusual presentation and strain, which we did have our review process with the CCG at that time, ICS, but also with Health HSA UK involved, where I can report that there were no lapses in care. All of our other infection monitoring and reporting that we do came under with a improvement reduction in all areas, and we will be continuing to undertake that and scrutinise against our national targets. The team also had investment into them over the last year and a half, and this has paid dividends, as I think you can see in the report, for maintaining our infection prevention control status.
Thanks very much for that quick canter through. Thanks very much for that. Any questions of Natalie? We've had lots of reports around COVID and infection control throughout the course of the year, so thank you. Gertie, equality and diversity.
Thank you, Chair. And I'll start off by just noting my thanks particularly to Natalie Cook and the engagement colleagues within People and Workforce for the preparation of a really good report. The report talks to us in terms of our progress and our areas that we are doing well in and the areas we need to work on. I'll pull out 3 or 4 key highlights, which is an increased number of BAME colleagues in employment over the year, now representing 23% of the workforce. Improved performance in relation to appointments of posts following shortlistings. That's gone from 6 to 14% for BAME colleagues. We've seen a decrease in BAME colleagues disproportionately being affected by formal disciplinary process. Areas that we need to continue to work on is the feedback we've had through the staff survey and have discussed previously in board around both BAME colleagues and colleagues with disabilities in feeling that they experience bullying and harassment from patients, carers, members of the public and other colleagues. And the ethnicity gap remains static in terms of major roles above band 5. And we've got a further discussion about the pay gap coming back to next month's board. A number of areas that we're doing well, particularly around our networks developing onwards, and it picks out and shows lots of areas where we have continued focus and more work to do. So a number of action plans at the end of the report, but I will leave it at that, Chair. I'm happy to take any questions.
Thanks very much. Thanks, Kirsty. Umar.
Thanks, Gertie. That's really helpful. I know we've been trying to get a time in the diary, haven't we, to meet, and we've got one now, so which we'll be looking forward to that. I think it's a shame really to hear that those figures are going in the wrong direction. Are we doing anything actively to try and look at those trends and put positive measures in place to try and tackle that? Maybe that's something we could pick up when we meet. More than happy to give some kind of experience of where we've done it in other organisations, which has had the similar challenges. Just to point out, this is not, the trust on its own. This is the NHS across the board. These types of challenges that exist. So I suppose the question is: are we doing anything from a being on the front foot point of view as a trust?
Absolutely. There's a huge range of actions being taken, from refreshing our values, setting out very clearly our behaviours and the behaviours expected of everybody in the organisation. There's a huge amount of support coming through the BAME network. There's revised training for managers in terms of supporting their staff for their wellbeing, to understand disabilities. There's a morass of actions being taken. It still remains an area of challenge, and as you say, not just for the NHS but for society in the main. So we continue to look at what other organisations are doing and gratefully receive any ideas or feedback, because this isn't an area that you can do too much in.
Yeah, I'm happy to touch base with you and look at that in a bit more detail. That'd be great. Thank you.
Thanks very much, Umar. I think there is. I was really encouraged to see the work of the staff network groups as well. That's something that's really taken off at pace, isn't it? Which is great to see. Thank you so much. And now over to Robin, and Kirsty might have popped back in, which is the Combined Health, Safety, Fire Safety and Waste Management Annual Report. Robin.
Again, I'll let Kirsty talk you through very briefly on the paper and take questions.
Hi again. So just some headline things on the report that just bring to your attention. So obviously COVID was still there last year at the forefront, and in terms of health and safety, in particular around managing outbreaks throughout the hospital. But even throughout COVID, we've maintained our health and safety audits being undertaken, and that's been an added bonus with the electronic health and safety tool that we've had. And our health and safety training has been maintained at 95%, which has been really good, along with our fire safety training at 92%, which both of those targets are above the trust average, or the trust target of 85%. There were 480 incidents, which was a reduction of 113 incidents on the previous year. And there were 13 incidents which were riddle reportable compared to the 43 from the previous year. So again, a reduction there. In terms of fire, we did have a visit from Warwickshire Fire and Rescue in May 21, and they undertook a fire safety compliance check report on the maternity building. And that resulted in us receiving a fire safety compliance check report with a number of issues that were identified as part of that audit. There were a number of recommendations and an action plan was developed, and they were supposed to be coming back in September, but they in November, but they cancelled due to operational pressures. And we're looking forward to welcoming them back next Tuesday so that we can demonstrate the work that's been undertaken, which has been significant in that building. going from infrastructure to fire training to all sorts of things. So it's a long way, made a number of leaps in terms of fire safety this year. In terms of waste, so it's increased by 46 tonnes in comparison to the previous year. And again, I think it's majority of it is because of disposal of PPE, and we've had a lot more activity going through the hospital in the year. In terms of, there's a little bit in figure 5 within the waste section, which we're going to improve on for next year, particularly around our recycling of items. We recycle everything that we possibly can. And you know, our general waste, 40% of it is recycled, and the remaining 60% is actually used something called refuse derived fuel, which in the olden days used to be called waste to energy. So it's being recycled, but in a different way. Our electrical waste, our waste is 100% recycled. Our clinical waste, which is the high temperature disposal, again, all goes to RDF. It sounds like a pop group, doesn't it? And then the confidential waste is 100% recycled, and there's a small proportion that goes to landfill, which is our clinical waste, and that's something that it's a mandate from the NHS about how we dispose of our clinical waste. So next year we'll look at retitling some of that to make it a little bit clearer. Other things that we recycle as well, medical equipment, it all goes off for auction. Toner cartridges, and we even segregate our garden waste. So there's an awful lot that we do to try and minimise that. So and that just summarises really the highlights of the report. Does anyone have any questions?
Thanks very much, Kirsty. Umar, is that a legacy hand?
Yes, it is. Sorry.
Okay, thank you. Thanks very much, Kirsty, and particularly concentration there around waste and recycling. Thank you. Thanks very much. That completes our section on annual reports. We've got some supporting information. Sarah, I'm going to say to you, I, as an audit chair, haven't got anything to raise particularly that isn't written there. Is there anything that you would like to draw to the attention of board from a quality point of view?
Well, thanks to Simone, who submitted. She chaired the meeting that we had in June, so she submitted a report. So we met in August on the 2nd and on the 30th. Just to note to the board that neither of those meetings were we fully quorate. We had good executive director support. We were lacking for quoracy in terms of the non-executives. However, it's not a decision-making group, and we felt with Natalie's steer as well that really the things we were discussing, we felt still able to recommend to board. Things we've covered today, so I won't prolong things really. Sepsis and deteriorating patient on the 2nd of August, we gave some focus to, and we felt there was reasonable assurance that we could bring to board there, but really wanted to put our weight and to ask the board to support Sepsis September and the ongoing work there. And then just of note, I know that non-executive colleagues are and wider are really very focused on our staffing, and with the people report we gave significant focus there on the 2nd of August, noted the mitigations that were in place, also commented that there was a real depth of understanding of the issues and the seriousness of some of our staffing issues, but also positively that there was a huge enthusiasm to continue to make George Eliot a really positive place for people to want to come and work and stay. So felt that was a real positive factor going forwards. And then finally, from the 30th, I think we've seen it in all the reports today. So the only additional thing to draw out, I think, was a focus in committee and an ongoing focus on falls and on pressure ulcers, and looking at the way that we report those, monitor those. And in summary, we will be looking at the way that reports come to the Quality Assurance Committee, and then in future how we can adequately report back here to board and make sure that you're receiving assurance from that committee appropriately. So thank you.
Thanks very much for that. I have nothing else to add in particular around my audit chair's report. Glenn, around the improvement board?
Yeah, just a couple of things to pull out for me. Firstly, within the report, you can see reference to the improvement story in that particular meeting was the same day emergency care development. And what was really good about this one is it's been a great piece of improvement work, but we also encouraged them to look a little bit more at the data to back up the evidence. And lo and behold, when they extended their data period a little bit more, it showed quite a dramatic improvement in the numbers of patients who are going through the SDEC pathway. Also good to see that improvement is being applied to the broadest range of things within our strategy. So the health inequalities, population health management, personalisation, all of which demonstrate that we're looking kind of beyond the hospital into the wider system. And it's always a great meeting to be part of because there's always such great work going on. That's all I wanted to say. Thank you.
Thanks, Glenn. It does look really positive in terms of outcomes from the meeting or outputs from the meeting. Any questions of Glenn or Sarah? No, thank you very much. We've then got information, the minutes from the Quality Assurance Committee on the 26th of June, 2nd of August, and the Audit Committee on the 31st of May and 13th of June for information. Assume no questions around that. Is there any other business? So oh, sorry, Anna. Anil?
Yes, Chair. Yes, Chair. Can you hear me? Sorry.
Yeah.
Chair, apologies. Chair, apologies. When you were at the first item, I was having technical difficulties. I just wanted to put on record changes to my register of interest. I have been appointed co-chair of Leicestershire Enterprise Partnership, and to balance the workload, I will be stepping down as a trustee for the air ambulance. I have notified NES and they will be updated on my register of interest.
Thanks very much and congratulations regarding that appointment. I fail very slightly in running over time, but I do want to open up to the public your opportunity to ask questions or make observations. Natalie.
Just congratulations to the board for getting the winter plan developed so early, but can you give some detail about how it works across the health economy in relation to, say, UHCW and Leicester with their winter pressures? Is it joined up? Is it discussed? I think you mentioned working with social care, but how does it work across other areas locally?
Thanks, Natalie. Glenn, do you want to?
Yeah, I'll take that. I was referring particularly to the national winter plan, which came out for the first time. But obviously, then what we do locally is develop a local set of plans, which are very much system focused. A lot of the activity relating to that goes through the A&E Delivery Board, which is chaired by David Eltringham on behalf of the system, and that involves all providers from Coventry and Warwickshire, including social care colleagues, ambulance service. So certainly in that forum, we have a lot of discussions with colleagues in Coventry about pathways of care. We've also, though, been tracking some of the urgent care activity that comes from other systems. So there's a direct relationship now with the Leicestershire system. Sadly, the evidence shows actually that patients who are treated out of area tend to have slower discharge processes, and some of that's the familiarity of the teams going into different social care services. So we've been working actively with the integrated care system in Leicestershire to improve that performance, and And actually, integrated care system colleagues in Coventry and Warwickshire have been helping with that also. So the whole approach to this is to join up our entire ICS plan for the winter. And I say David's in the role of keeping an oversight of that on behalf of the system, and I then report that up through the Integrated Care Board, as I'm technically the SRO for that, because we try and ensure one of the execs at the board is responsible. So and a lot of work going on, and obviously some of the things we discussed earlier could also improve that. So earlier today in workshop, we were talking about our discharge to assess pathways and whether there's an opportunity to improve those over the winter. And I can see that Robin wants to say a little bit more.
Thanks, Glenn. Robin?
Thanks, Glenn. Thanks, Chair. Yeah, just to localise it a bit, we are in the process of completing a return to the system on a standardised template that's national template. That return we're aiming to get back by the 14th of September. So that is moving on at pace. Over the last couple of weeks, the directorate teams have been working with the teams across the site in order to gather their comments and their thoughts about the winter plan and what should be included, because I'm very conscious, and something I've impressed on the directorate teams of the most successful winter plans are those that are generating the ideas from the teams themselves from the outset. So that's part of the process, and what we will be doing for our own governance assurance for our own winter plan is to bring that through TMB on the 27th of September as a plan to come through to board in October for a review. So that's the structure that we're following at this point in order to bring that forward.
Right. Thank you. That's quite helpful, because I think in the public we often hear about ambulances being diverted from one hospital to another, and obviously that helps probably ease the pressure, but it does cause increased pressure on, I know, the Eliot. So thank you.
Thanks very much, Natalie. Are there any other questions? Is that just a legacy hand there, Natalie? Have you got a second question? Just a legacy hand, I think. Okay, thanks very much. Well, thank you to everybody. Slightly overrun, I'm really sorry. The date of the next meeting is the 4th of October, where it'll be looking forward. Russell will be back then. I'm looking forward to seeing everybody then. For my colleagues, for our next meeting, could we have just a 10-minute break, please? I make it 3:37, so 3:47. I'll see you in our next meeting. Thanks very much.